Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello everybody, I am the Millennial Mechanical Therapist, and today is part 2 of post-surgery response to repeated movements. So before, if you're watching this, you've seen the first video, and I think the message is going to be relatively clear throughout all of these. There's about 4 of these cases that these individuals have been not medically mismanaged, but things haven't gone their way, or whether it was through whatever insurance they had to kind of fight through or get more visits from. Time has elapsed for these individuals, and throughout that time they've either maintained some sort of dysfunction in their movement capabilities as well as pain, and also they've maintained that and gotten new types of pains, and thus seeing me. So this individual who today's video is on was a previous patient of another therapist in a different clinic affiliated with ours, and she about a year ago underwent a rotator cuff repair and some arthroscopic work as well. She went through about 6 months of pretty intense typical physical therapy, which included manual therapy, mobilizations, soft tissue work, and therapeutic exercise, and possibly some modalities thrown in there as well. I'm lucky, since she was a previous patient, that I had access to her charts and could see that. So coming into me, I didn't want to give her the same old song and dance. I mean, she's been, she went through that. If 6 months of intensive physical therapy, getting everything under the, everything under the umbrella, the shotgun approach of throwing everything at her didn't work, what the heck is going to? I have to bring something new to this individual. So, as I always do, I looked at her through, my glasses, so to speak, of MDT, or mechanical diagnosis and therapy, specifically through repeated movement testing and prolonged static positioning testing. And what a turnaround for this individual, and I'll tell you a little bit about her. So she's still year out, a little over 6 months past traditional or the shotgun approach physical therapy. She continues to have moderate loss of flexion and abduction of the involved upper extremity, moderate loss of functional internal rotation, and small loss of functional external rotation. So, and she also had end range pain. She didn't have pain during movement through all these things. She had end range pain in flexion, abduction, and internal rotation and extension. So I bring her through repeated movements. Now, some of her symptoms were a little different. They kind of sounded more cervical in nature, because I believe she had some numbness and tingling that went from the shoulder all the way down to the wrist. And we were able to influence that through movements of the neck. So not only was this individual post-surgical, but she also had neck-related issues as well. Who knows truly if before going into surgery everything was coming from her neck or her spine, and she just didn't see the right individuals, got pushed around, got pushed into the wrong thing. Who knows? That's not what we're here to talk about. So we go through day 1. Halfway through day 1, we see that cervical movements, specifically in the directed at a posterior derangement, if you're familiar with the McKenzie terminology, was able to significantly help her numbness and tingling, but had little to no influence on any movement of her arm besides forward flexion. So we exhausted that 50, 60, 70 repetitions of retraction with overpressure, retraction, extension. Still no influence on abduction, or internal rotation, external rotation, extension. or the end range pain that she was experiencing in her limited motions. So we went through and screened the right upper extremity. So the upper extremity goes through, and we find that extension just actively decreased pain that she was feeling locally in the shoulder and increased her range of motion into abduction and then functional internal rotation. So not only is this individual presenting as a neck derangement, but also a shoulder derangement, which responded to extension-based movements. So who knows what the heck came first? I mean, did this individual originally have cervical referral patterns that was medically just not managed well and she ended up getting surgery? Did she have a pure shoulder situation that after months of physical therapy, a year or so of life, she just happened to have neck pain at that point in time as well, or neck a situation with her cervical spine at that point in time? Well, who knows? And why does her shoulder respond to repeated movements? I don't know. Makes no sense that post-surgical. I mean, the time frame is right. She's at 6 months, and 6 months, to a year of cranking on that shoulder, something new could have happened. Day 2 comes around, and she's kicking butt. I mean, she's greater than 25% better, self-reported. She has an increase in all range of motions and a localization of her pain directly to the shoulder. Really wasn't experiencing any numbness or anything like that. So, we sent her off, and she's, continuing on doing well. But here's some individual who experienced, the typical shotgun approach. It didn't work 100% for them, was able to get back into someone else's care. And through a different, different glasses, different view, we were able to find that, just giving her the chance to respond to repeated movements and be doing our due diligence to look at her spine, this individual is going to do a heck of a lot better than she would have just going the same old song and dance. So again, the moral of the story of today is the same as it was last time. I mean, these individuals who come to you post-operative, especially those that are, I think the theme, a lot of the, I'm going to put a list of some of the commonalities between these individuals out there, but the theme being, the surgeries and the sequelae from the surgeries prolong and continue on. They look at repeated movements, look at static postures. I mean, worse comes worse, you don't find anything, but man, how awesome would it be to help these individuals out quickly and efficiently and get them on their way. So stay tuned. We got part 3 coming up soon about another shoulder, and then we'll talk about a lower extremity case, all post-operative, all responding to repeated movements, mechanical diagnosis, and therapy. Move your patients, friends. I hope you learned from us. Have any questions, let us know. Find us on Facebook. Check out our website. Move your patients early, move them often, and move them till end range, my friends, because that's where the magic happens. We'll see you next time.